All right, so we're going to talk about cricothyrotomy, needle and surgical airways. This will be kind of the pre-education for the skills day that we're doing on the 28th following our meeting. So objectives, we'll get through these pretty quick here. We're going to define emergency cricothyrotomy, what it is. We're going to outline the WALS manual for emergency airway management, emergency airway algorithms, and where cricothyrotomy falls within those algorithms. We'll review anatomical structures and landmarks. We're going to discuss the difference between the needle and the surgical airway. We'll describe the indications for each of the two procedures. We'll review what our protocols are here and what certification levels do which procedure. We'll discuss some of the common complications that are encountered with each of the two procedures. We'll identify all of the equipment that we need to complete each of the two, and we'll demonstrate in some videos towards the end how to effectively complete each procedure. So what is a cricothyrotomy? I think everybody probably has a pretty good understanding of what this is, but this is considered to be an invasive airway procedure. Basically, it's something that's used to obtain a patent airway in a patient when other routine methods, your ET tubes, your supraglottic airways, bag mask device, when all of those have failed. And it's often a life or death type of situation, that last ditch attempt at getting a patent airway. So when we're talking about the WALS Manual of Emergency Airway Management, I think that everybody here, or at least everybody here should have a pretty good understanding at what those algorithms look like. These are all highlighted in great detail in our patient care guidelines in the airway management section. But basically, to sum this up, these are guidelines that are put in place to minimize hypoxia and other adverse outcomes during attempts at airway management. So what it focuses on is predicting a difficult intubation and being able to have a clear-cut, concise approach to how we're going to handle that. So just to sum this up, this basically is all catered around that difficult to intubate patient. So as a group of people performing a resuscitation, if the patient has had 3 failed intubation attempts, so 3 attempts, it could be 3 different people, it could be 2 people, it could be 1 person completing all 3 attempts. If those have all failed, then we need to progress down the algorithm, and what we move to next would be that supraglottic airway. Now, if we can't utilize that supraglottic airway for whatever reason, then we progress down the algorithm, and we've at this point either found out that we cannot ventilate and oxygenate the patient adequately with a BVM, or we're finding out at this point in time, and this is when we need to jump into the surgical cricothyrotomy or a cricothyrotomy of some sort. Okay, so this little flow chart here, this is adapted from the WALS difficult airway algorithms or emergency airway algorithms. But looking at this, and the reason I like this one is it actually, aside from just giving you the, point A to point B type of description, it actually gives you some little tips, tricks on how to be more successful with the intubation aspect. And so this was found on mcrit.com. If any of you guys want this, let me know. I'll send it to you. Otherwise, you can take a screenshot of this slide and crop it out, and then refer back to it if you guys ever need it. So when we're talking about the anatomy, really what we're focusing on here is the anterior neck, right? So there's a lot of really important landmarks when we're talking about the anatomical structures, but the big thing to keep in mind here is your thyroid cartilage and where that cricothyroid ligament or the membrane sits right below. Now that's highlighted in green and it's marked by the letter A. But if everybody were to put their fingers, to their neck right now, I think that everybody should be able to find their cricothyroid membrane. And in all reality, on most patients, we should be able to find this pretty easily. Why this slide is important is because, we may encounter patients that have larger body habitus, and it may be difficult to palpate that area. So being able to refer back to the anatomic structures and being able to at least find something and walk down the patient's neck and be able to figure out where exactly or in a general vicinity that that cricothyroid membrane is going to help us out tremendously. So let's talk about needle cricothyrotomy first. So in the Iowa paramedic scope of practice, this is approved for all patients, okay? And this is for general paramedics. The needle cricothyrotomy is accepted, okay? Now, when we're talking about patients that are under the age of 8 years old, this is the method that should be used on that population of patients, your pediatric patients. Now, the reason for this is because it's said that patients that are less than 7 years old have not quite developed their airway all the way to where it's similar in structure, not in size, to that of an adult's airway. And so we all know that the pediatric airway before this point is soft, more pliable, it's narrower, and the big thing is that cricothyroid membrane is going to be significantly smaller. And so this is why on these patients we need to use needle rather than surgical. So indications for this, obviously we can't get the patient intubated, all of their means have failed, and we need to oxygenate the patient. So typically this is done by inserting at a 30 to 45 degree angle a standard 18 to 14 gauge angiocath. So generally larger diameters are going to be our best bet as far as being able to move air through it. So keep that in mind. Otherwise, if you've got some very, very small pediatric patient, you may have to use smaller than a 14 gauge. So obviously we're pushing this through the cricothyroid membrane, and understand that, when we're using a angiocath, a little small catheter, we're going to be able to force air through that, right? We can sit there and we can squeeze a bag and we can force air through that catheter. But the portion of this that's going to be difficult, and yes, it might be hard to squeeze, but the portion that's going to be difficult and it's going to pose us the most complication here is the fact that we're not going to be able to get air back through it. It's going to be exceedingly difficult to ventilate the patient. And that's why setting up, like jet insufflator type of devices, and in the video here later, they'll show you a method on how to make one of those, is going to be very beneficial. So this is really going to be a means of oxygenating the patient, not ventilating. Now, that being said, since we can't really adequately exhale for the patient, this procedure is something that really, in all reality, is only and should only be used for 30 to 40 minutes tops. Now, that should be enough time to get to an ED to where they can, utilize some other means. But really, this should be something that we are looking at as a true rescue type of attempt, and not hang our hat on for the long run. And the reason for this, and something we should anticipate, is hypercapnia. And we know that small or short periods of time of hypercapnia, that's elevated, but not sky high, is okay. But as we go longer periods where a patient is hypercapnic and that CO2 climbs and climbs, then this is going to be very deleterious. So we certainly need to keep this in mind when taking care of these patients. All right, so we're talking about the quick trach. So quick trach, everybody should be familiar with this. We stock these on all of the ambulances, or at least an adult version of this on all of the ambulances. And what this is it is a percutaneous type of approach to to establishing an airway through that cricothyroid membrane. Now, this is considered to be a needle cric by the scope of practice for paramedics in the state of Iowa. So your typical paramedic, not CCP, can do this procedure. Now, the benefit of this, when we're looking at these, you can see that it's a much larger diameter needle, and over top of that needle, the airway slides right in. And this airway also has inflatable cuffs, so it really does provide a good seal, and it will also provide better ventilatory effort through the airway. So while you're still not going to be able to ventilate through it as well as if you were to stick an ET tube or a Shiley or something through the membrane, you're going to be able to ventilate better than you would through your typical angiocath. Okay, so the device itself really is a better option. It's also considered to be a short-term type of device, and we should still expect to see some level of hypercapnia. Okay, so we're going to talk about the equipment needed. So when we're talking about our just normal needle cricothyrotomy, what we need to complete this, obviously, some type of antiseptic, sponge pad, chlorhexidine, betadine, alcohol, whatever. Now, while this is considered to be an emergency type of intervention, we really should do our due diligence to make sure that we're not, introducing any bacteria or anything to the patient that's going to cause complications down the road, sepsis and things like that. We'll obviously need a angiocath. Remember, bigger is the better. And that being said, obviously, we do have bigger options that we would use for our, needle decompressions, 10 and 12 gauge angiocaths. But while there's a larger diameter, understand that those catheters are much longer. They're 3¼ inches to be exact, which is quite a bit bigger than our standard 1.5" IV catheter. So that longer length is also going to add to the resistance. So I don't know which would honestly be better, but there's going to be some trade-off that's going to make your 12 gauge decompression catheter versus your 14 gauge IV catheter. They're probably going to be pretty close to the same as far as resistance goes. You're going to need a saline flush. Now, we use the saline flush mostly because once we place that catheter, we can hook the saline flush onto it. And if we're in the trachea and we pull back, we should see bubbles in the flush. Tape, obviously, this is more or less for securement. And, we really get creative with this. However you accomplish it, it doesn't really matter if you chevron the tape, but just some way to secure this airway. Because remember that at this point in time, this truly is literally this patient's lifeline. So it needs to be secured in a at least somewhat good fashion. We're going to need a 3 cc syringe. Now you'll notice that I put just the barrel here, and the reason for that, we're going to take the plunger out of the syringe, and we're also going to take a 7.5 ET tube, and we're just going to take the ambu bag connector off of it, the part that we plug the bag or connect the bag to the tube. We're taking that off, and then we're going to go ahead and put that inside of the 3 cc syringe, and then we're going to utilize the lure lock of the 3 cc syringe as an adapter for the ambu bag so we can ventilate through that. There's a little diagram over here on the side you guys can see, and it just kind of shows how this is accomplished. And there's a couple other methods that exist out there, and this doesn't necessarily have to be the way that we do it. I mean, do whatever you learned if it works, but just make sure that you have some way of making sure that you can ventilate the patient with a BDM. So, the quick trach. Basically, all the contents we need are in the kit, and I think everybody's probably seen this. If you haven't, you really should. The first time that you're seeing, what's inside of these kits really should not be when you need to use it. But you'll see you've got the needle, you've got the airway, you've got a couple syringes in there. One syringe for saline, and then the other syringe is for your inflation cuff. I would probably just toss the empty syringe in there that you're supposed to fill with saline, because that would require you to access a bag and pull some saline out. So just take a flush and replace it with the empty syringe that's in there. And then it's got a foam securement strap that goes around the outside. So you guys will see in the video here, it has little wings on it, and this strap has Velcro on either end, and it just goes through, and it's easy to secure just around the back of the neck. All right, so surgical cricothyrotomy. So this is a skill that is approved for critical care paramedics under the Iowa scope of practice. So this is something that is that we've already mentioned. It's appropriate for patients that are greater than the age of 8 years. Some people may have learned that 12 years old is the cutoff, and it really depends on the textbook you read. It really depends on what school of thought you're subscribing to, but it's generally accepted that a patient that is at least 8 years of age has their airway is developed enough to be able to do a surgical cric. Now, use your best clinical judgment if you ever end up in this situation. If you've got a very small 8-year-old, it may not be appropriate to take a scalpel to the front of their neck. So this obviously is something that we really need to use our best judgment on. So that last ditch attempt in the patients that need emergency airway management. As we mentioned, going through that algorithm, this really is, that last effort to get an airway for a patient. So oftentimes this is something that's going to be not only, a dire skill that needs to be accomplished, but it's also going to be something that's going to be a very high anxiety type of situation. So knowing how to do this and kind of going through and thinking about how you'd complete this procedure is very, very important. And knowing where those landmarks are and knowing the equipment that you have is very important to just think about just in general on a day-to-day basis, or when you're doing your practice intubations. It really is something that we need to be considering, because the reality is, if you find yourself in this situation, you're definitely going to be, a huge adrenaline dump, very nervous. It's going to be something that's, definitely going to get your blood pumping. So you really do need to practice and, go through the steps mentally. And when we have the opportunity, practice the skill and know where your equipment is. So generally this is accomplished by using a scalpel to make a vertical incision to expose the cricothyroid membrane, and then puncturing that membrane to place an airway. So some people probably learned the horizontal incision method, but that 3 centimeter incision vertically is going to not only give you more surface area in that incision to where you can see it, gives you a bigger window, but it's also going to be a little bit safer, and you'll have less of a risk of cutting through a vessel at that point. Now there's going to be blood, there's going to be a lot of blood, but it might be less blood than if you were to cut through a larger blood vessel. So just keep that in mind. Right now what they're teaching is a vertical incision, and then exposing the membrane, and then making horizontal incisions through the membrane itself. So this is actually considered to be a definitive airway. So once you get an airway in here, they're going to use this as the patient's airway probably throughout their, when they get to the ER, their ICU stay. whatever the situation may be. They can attach a ventilator to this. This is going to be their airway. So this is a excellent option when all other options have been exhausted. Obviously, some of the complications that we may encounter with this, we've already mentioned: blood, probably lots of blood, and possibly some anatomical issues. And this really does come down to the fact that no two people's bodies are the same, and there could be some major structural differences between one person and another, and we really might have a little bit of a difficult time with some of these patients that have different anatomical features that could really make this a lot harder than we anticipate. So when we talk about the equipment needed, now there's a ton of commercial kits that are available. Like in the ED crash carts we've all seen, we've got the Melker Cric kits, and those are a percutaneous type of option where we insert a needle, a guide wire, and then slide the trocar over the guide wire, or make a little incision, then slide the trocar over the guide wire, and then push that little Shiley type tube through there. There's a bunch of other options that exist commercially. What we are using with the ambulances comes from the scalpel finger bougie type of approach. Now, this is more or less the most accepted method for cricothyrotomy in the pre-hospital environment, and the reason for this is because it really takes a lot of these standard pieces of equipment and I don't want to say repurposes them, but makes things easier because they're more easily available, they're widely available. There doesn't have to necessarily be a designated kit. As long as you have a scalpel, you should have the type of equipment that you need to accomplish the task. So what we have, and we do have prepackaged kits. They are opened and modified and vacuum sealed, and that's what we're using. But ultimately what we have are aseptic sponge pads. So we've got chlorhexidine, we've got number 10 or 11 scalpels, a 6.0 ET tube, and the 6.0 ET tube is what we need to use. That's the typical size that should be used for adults. We've got an adult bougie. We've got a 10cc syringe for the inflation cuff, gauze sponges, and then we'll either use tape, cloth, or a commercial securement device. We've got some like trach wraps in our kits. Otherwise, if you don't have this, you can always take a Thomas tube holder, like what we'd use for ET tube, and invert that so the bite block is facing out, and use that to secure the device. Once again, these are prepackaged. They are in all of our airway kits, pretty clearly labeled and available should you ever need one. So when to do a cricothyrotomy? So by and large, the only time that we truly do have a emergency or an airway emergency is when we are in a situation where we cannot oxygenate and we can't ventilate. So in these situations, there could be a number of different causes, but that's the only true time and the number one indicator for why we would do a cricothyrotomy. So some of these situations that may cause this could be trauma, trauma really to the head, to the facial structures, could have trauma, to the neck. Any type of trauma that may contribute to this could be an indicator. That blood from a maxillofacial type of trauma, that's, obstructing our view, or vomit, things like that, that just make it impossible to visualize the cords during an intubation attempt, could be an indicator that we may need to do a cricothyrotomy. Facial muscle spasms or laryngospasm, uncontrolled emesis, upper airway stenosis, or congenital deformities, somebody that just has anatomical abnormalities that they live with. Clenched teeth, this could be from a TBI. It could be a patient that has MH or malignant hyperthermia from when we administer succinylcholine. A patient that has a tumor, cancer, or any other disease process or trauma that causes a mass effect within that upper airway that makes endotracheal intubation difficult or impossible. So we're going to talk about a couple mnemonics here, and we really could do an entire different presentation on difficult predictors for airway management. But just so we have a couple of these to fall back on, and these are going to kind of build on one another, but we're going to go through the Moans mnemonic, Heaven, Rods, and Short. So difficult BVM predictors. So Moans. M stands for mask seal, bushy beards, crusted blood on the face, disruption of the lower facial continuity. So that mandibular fracture. Obesity or obstruction. So obviously our larger patients, this is going to be a little bit more difficult to bag them, not just from a mask seal perspective, but also from the extra weight that they're carrying over their thorax. Pregnancy, we know when you get a big gravid belly that we push up the diaphragm, and that can be difficult for bag mask ventilation. Angioedema from a anaphylactic type of encounter. Ludwig's angina, or upper airway abscess, or of course epiglottitis. Any age greater than 55 years of age, and the reason for this is, it's always, there's a number of things to consider, but by and large, your skin, after you get past a certain age, starts to lose some of its elasticity, and this can actually pose a little bit of a problem when it comes to just generally getting good mask seal. No teeth, so that patient that has dentures, if we're going to be doing bag mask ventilations, we should try to keep those teeth in, because that's going to provide us with better facial structure, so it'll make it a little bit easier to bag the patient. We've all seen those patients that take their dentures out and they get that kind of sunken mouth type of appearance, and that could be very difficult to get a good mask seal and bag the patient. And then sleep apnea or stiff lungs, patients that are, chronic COPDers, those patients that, their tongue obstructs their airway, those ARDS patients, which in acute respiratory distress syndrome, really the reason why this is difficult is because we're bagging patients, and it's more of a pressure problem. So let's talk about Heaven. So everybody's probably heard of the Lemon mnemonic. This is a recent improvement or adaptation of that mnemonic, and this is more specific to us in the pre-hospital environment. So H stands for hypoxemia. Now obviously when we've got a patient that's hypoxic, it's going to be very difficult, because we don't want to have our patient have a critical desaturation. Really, we don't want them to fall below 93%. And so when we've got somebody that's already hypoxemic, it's going to be difficult. We're going to really have to focus on that pre-oxygenation phase, but this could definitely pose some complication in that peri-intubation phase, so that we don't end up making the patient worse, or heaven forbid, making them arrest. Extremes of size, as we mentioned, patients with larger body habitus, they're going to have more tissue, more weight, positioning wise, we're going to have to, probably ramp these patients up. It's just going to be more difficult. Anatomic abnormalities, the list could go on and on with these, but certainly consider, the patients that, might have a mass in their upper airway. They might have, other types of problems that could make visualization of the vocal cords difficult. Vomit, blood, fluid. So obviously, any vomit or any fluid for that matter, or any debris, could be dirt, grass from a road ditch, anything in their airway, that's obviously going to make visualization of the cords difficult. Exsanguination, and it really should say exsanguination or hypotension. So any patient that's hypotensive, we all know that during intubation we have a tendency to drop the patient's blood pressure. We normally will make them more hypotensive, either by vasovagal effect or by administration of the medications, the pre-medications that we would use for intubation. So this is definitely something to consider. We really do need to try to take the time to augment that hypotension, whether that's through fluid bolus, push pressors, whatever situation or whatever intervention that we choose, we need to try to bump that blood pressure up a bit before trying to intubate them. And then neck mobility. Now, patients in a C-collar that has potential cervical spine compromise, we need to try to pop that collar so we can get a little bit better mobility, more or less for us, so that we can see. Now, if we're giving a patient a paralytic, this shouldn't be a huge concern, but definitely if we're doing this, have somebody hold C-spine from the front. So rods. Now, this is indicator for difficult supraglottic device placement. So supraglottic, what we're talking about is, our devices like the King tube, the LMA, or, the iGel. And this mnemonic basically is pretty straightforward, but R stands for restricted mouth opening. So if you've got somebody that can't open their mouth wide enough to stick one of these devices in, that's obviously a problem. We all know that the diameter of all of these devices is, pretty significant. I mean, based on the size that's appropriate for the patient, I mean, they're rather large in diameter. And the other thing to consider, with the iGel aside, is that these devices generally have large cuffed balloons that, need to be inserted. And so if we can't open the mouth wide enough, or if we're forcing it in, we may rupture the balloon. Obstruction, so any real true contraindication for these is any upper airway obstruction. And this could be from, soft tissue trauma to from, burns, or whatever other situation. This definitely needs to be something that we consider. Disrupted or distorted airway, this could be from trauma, it could be congenital abnormality, but definitely anything, these are intended for normal anatomy, so if there's anything that's in there that's going to displace them in any way, shape, or form, they're probably not going to work. Stiff lung or cervical spine, so obviously back to the C-collar, this is going to pose a little bit of a complication as it pertains to placing the supraglottic airway if we aren't able to pass the device or seat it in the appropriate position. And then stiff lungs, and this is more of a problem with the iGel, but if we have a patient that's got ARDS or a chronic COPD, or that's got a lot of pressure down in their lungs, the more pressure we put in, the more likely we are for that pressure to backlog and displace our supraglottic airway. Okay, so all of that kind of builds up, and it's all stuff that we should consider, because it all kind of paints a good picture on whether or not we should anticipate a surgical airway. But mnemonic that we can use to determine whether or not a surgical airway, or a cricothyrotomy in general for that matter, is going to be difficult is the short mnemonic. So S stands for surgery. Any patient that's had any previous surgeries to the anterior neck, or really any portion of the neck for that matter, this may be a indicator that there might be an anatomical disruption, and it may be difficult to find our landmarks. Hematoma, hematoma. So this is any mass to the front of the neck. A patient hits their neck on the steering wheel, or they have an abscess or anything to the front of their neck. It's going to obviously cause swelling, and it's going to not only give us more tissue that we're going to have to dissect through, but it could make identifying landmarks more difficult. Obesity, this kind of goes without saying. People with larger necks, it's going to be much harder to find the landmarks that we're looking for. Radiation, so somebody that's got a large thyroid, this can also cause some complication. And then obviously tumor. If they've got a big tumor on the front of their neck, that's going to be very difficult. So we're going to watch a couple of these videos just so that everybody can kind of see what we're working with here. I've got a video for the needle cricothyrotomy. We've got a video for the quick trach, and then a surgical cricothyrotomy video. They're all pretty short, so just bear with me.
Hi, this is with Cape Town Emergency Medicine. Today demonstrating needle cricothyrotomy. Needle cricothyrotomy is a temporizing way to deliver air to the lungs once conventional airway maneuvers have failed and while you are awaiting definitive surgical control of the airway. The first step would be to correctly identify the landmark for insertion of the needle. The needle should be inserted through the cricothyroid membrane. In a live patient, this is identified by palpating the prominence of the larynx or Adam's apple, this is the thyroid cartilage, and sliding the finger caudally until you get to the membrane between the thyroid and the cricoid ring. In an anatomical model, this can be clearly seen as the thyroid cartilage and the cricoid ring, with a cricothyroid space in between, which would be covered by the cricothyroid membrane. When sliding the finger, the gap is usually easily felt. Before performing the procedure, ensure that you have the correct equipment available. You will need a large IV cannula, at least 1, 2 or 5 milliliter syringe, and a ventilation device with a side port with oxygen tubing to connect to wall oxygen. To perform the procedure, attach a 2 or 5 ml syringe to the back of your IV cannula, and then clean the area of the Adam's apple and laryngeal prominence. You would then identify the cricothyroid membrane by sliding the finger down and feeling the cricothyroid membrane there. Firmly stabilize the larynx with your one hand. In your other hand, grab the needle and syringe and pass it through the skin. Aim 30 to 45 degrees caudally and gently advance the needle until you feel a pop as you pass through the cricothyroid membrane. Aspirate air to confirm that you are in the airway. Keep control of the needle and advance the cannula into the airway. Remove and safely discard the needle and syringe. Connect your side port ventilation device to the patient and connect oxygen tubing to the wall and to your device. You can now deliver some oxygen to the lungs of the patient by occluding the side port for 1 second and allowing it open for 3 seconds. 0, 1, 0, 1, 2, 3, 0, 1, 0, 1, 2, 3. Please note that this is only a temporizing measure and definitive control of the airway has to be gained as soon as possible. In order to manufacture easily in your own unit the side port ventilation device such as this, follow the following steps. You will need a 2 ml syringe, and the connector port from the back of a standard ET tube. Remove the plunger from the 2 ml syringe. Use a blade or knife to cut a side hole in the side of the 2 ml syringe as shown. Take the ET tube connector and insert it firmly into the back of the 2 ml syringe. This device is now ready to be connected to the cannula on this side and the oxygen tubing on that side. And that is it. Correct insertion of a needle cricothyrotomy.
Okay, so we just watched the needle crike, and that kind of showed you guys how to make a makeshift jet insufflator. That's a good option, and I like the way that they did that. Actually, prior to seeing that video, I hadn't seen that particular method done. There's another way to do it with the meconium aspirator that we will talk about during the skills portion of this, but I think that option is definitely going to be the best for us in the pre-hospital environment because we don't carry meconium aspirators. So now we will show the quick trach insertion video here.
Okay, I'm going to demonstrate the insertion of the Quick Track 2. This is an emergency cricothyrotomy kit for emergency access to the airway through the cricothyroid membrane in a situation where you can't intubate and you can't ventilate the patient. This is how it would become in the packet. So you would have a red and a green stopper, and it would be attached to a cuff. There's 2 syringes in the packet, and you would start by inflating the cuff to check the cuff is inflating, and then you need to fully deflate the cuff. You need an ampule of saline. So the landmarks would be the thyroid cartilage above and the cricoid ring below, and between the two is the cricothyroid membrane. You need to get your syringe with saline, attach it to the Quick Track 2. Okay, find your landmark. You need to insert and aspirate at the same time, and as soon as you get air aspirating, which you can see through the saline, then you can stop. You can click back the green stopper. You should hear an audible click. This is retraction of the needle into the cannula. Remove the red stopper. This is to prevent advancement into the posterior tracheal wall, and then advance the cannula. Aspirating all the time. Once the cannula is at the skin, you can then remove the needle. Then you would need to get your other syringe and inflate the cuff, and then use the ambu bag to check that you can ventilate the patient using a capnograph trace.
Okay guys, so this is the last video here. Now understand there's a ton of videos on cadavers, and there's actually some on some live cases available on YouTube, and they're awesome. It's going to be the most realistic option. The reason why I chose this video is mostly because this guy does a really good job at verbalizing everything that he's doing, and does an excellent job at describing every single step of the surgical airway. This is going to be the procedure that we're going to be using, that scalpel finger bougie type of approach, and he does a really good job with the simulated skill anyway.
Okay, listen up, everybody. We're running into trouble. The stats are continuing to drop. We're in a can't intubate, can't ventilate or oxygenate situation. Let's call for help. Call ENT and anesthesia. Get another emerg doc in here, please. Okay, break out the cric tray there, or the cric kit there, please. Okay. So we can't intubate, can't ventilate. John, get ready to take over ventilations. Have everything ready there. Okay, go ahead and take over. We're going to hyperextend the neck to position better for surgical airway. Get the prep ready, please. Okay, thank you. Everyone get PPE on. Everyone face shields, please. All right. I'm landmarking here. You have the scalpel, bougie, 6 endotracheal tube lubed. Okay. Laryngeal handshake, midline. I can feel the thyroid, cricothyroid membranes right there. Left hand stabilizing the thyroid. I'm midline, scalpel cut. Feel the tissues through the subcutaneous cricothyroid there, inferior margin. Cutting left, cutting right.
Vertical incision, and now he's making a horizontal incision.
Confirming the hole, dilating it. Bougie, please. Okay, bougie over my finger. Feeling the tracheal tics hold up. Tube going through. Cuff going through here now. Cuff up. Bougie out. Make sure the oxygen's hooked up there. BVM on. And tidal CO2, please. Check a pulse there. How are we doing? How's our SAT doing there? Do another set of vitals, please. Listen to chest rise and fall. Got end tidal CO2. Make sure that probe is on properly, please. Thank you. Run another blood pressure, please. Still got good end tidal CO2. Okay, cuff is up. Got the tube secured, airway. Breathing, you got good air entry bilaterally. C circulation, what's the blood pressure doing now?
Okay, guys, so that was a pretty good example of the surgical cricothyrotomy. So that completes the education portion of this. Thank you guys for bearing with me here for the last 45 minutes or so. That's just what we had to do in order to get the CEs for this skills day. So what we're going to do on the 28th is Wings Air Rescue is going to bring in some surgical skills mannequins, and we will do needle airways, quick trachs, and then the surgical airway. Paramedics that aren't CCP, it would still be beneficial to do the practice for the surgical airway if we're able to do so. That way, if you do want to go and do the critical care thing, you can, and then you've got a little bit of practice. But then also, so everybody can be part of that procedure, so we know what equipment to have ready, and then kind of to get that teamwork dynamic as far as the scalpel finger bougie type of approach requires. So we'll do all of this on the 28th following the meeting, and so thank you guys very much for your time.